Welcome to this postgraduate lecture series as part of the MedEClasses initiative in which we try to cover the entirety of pediatric endocrinology over the 36 modules covering different aspects. And we have been covering electrolytes for the last few months. We already covered hypo and hypernatremia as well as hypokalemia. So today we're going to finish off the electrolyte module using the module on hyperkalemia. Now, hyperkalemia is a scenario which is usually an acute emergency and we don't encounter in terms of chronic causes, but that can have huge implications in terms of evaluation and management. So we had this 1-month-old child who presented with reduced feeding, and this child had not gained weight at all in that perspective, and investigations showed hyponatremia and hyperkalemia. So usually we talk about sodium and potassium being linked. And when we discuss electrolyte, we said that whenever your sodium goes down, generally the potassium goes up. When your sodium goes up, the potassium goes down. So this is again going a situation where the sodium is low, potassium is high, suggesting that there is a problem in the renin, angiotensin, aldosterone system. Now, further workup, of course, the first thing you will consider in a child would be to exclude congenital adrenal hyperplasia or adrenal hypoplasia congenita. 17-hydroxyprogesterone and cortisol levels were both normal. Now, if we go further our algorithm, we found that PRA and aldosterone levels were high. So we had a child who had a high aldosterone and despite that had hyponatremia and hyperkalemia, indicating that we are dealing with an aldosterone resistant state. So this led to the diagnosis of quote-unquote pseudo-hypoaldosteronism. But here comes a catch. So whenever you're making a diagnosis which is rare, you have to think of other possibilities. And we'll discuss subsequently that a pseudo-hypoaldosteronism-like state can be induced via infection and obstruction. So this actually happened to be a UTI in the setting of obstructive uropathy, which resulted in a transient aldosterone resistance, and that caused this scenario. So whenever you're diagnosing these scenarios, think about obstruction and infection, which becomes important in that regards. Now, this is the format which we'll follow. We'll start off a bit about pathophysiology of hyperkalemia. Then we'll move forward towards criteria and etiology with Dr. Vibha. We'll be discussing about, then I'll touch base about assessment and management. And finally, we'll have a quick, interesting scenarios and question answer sessions which Dr. Manoj will take forward. So all of you can participate in that using the chat option subsequently. We'll also be taking the questions at the end of it in that perspective. You all can go and have a look at our website, learning.growsociety.in, where there are a lot of resources with regards to pediatric endocrinology, besides a number of courses and our e-learning portal in the YouTube channel, and the various courses which are available, including fellowship programs, diploma programs, and we have an exclusive course for postgraduates which covers all these modules over a 3-year period, specifically for pediatric postgraduates in that perspective. You can also follow our grand rounds, which are more in a pediatric endocrine perspective, symposiums which happen regularly, in this PG lecture series, which we plan over the next 3 years to complete the entirety of pediatric endocrinology. You can also have a look at our multiple publications, which are there also in the form of physical as well as virtual platforms and a mobile application. The goal of management is primarily to protect the heart, because that's what the major problem happens in hyperkalemia. We need to have an immediate reduction followed by a sustained reduction from a long-term perspective. But first, protect the heart. Now, if you have clinical symptoms like paralysis, syncope, if there are ECG changes, that's urgency. And if you know that this potassium is going to increase, you need to be more bothered in terms of treatment. You have to very carefully do a continuous ECG monitoring, because a lot of problems can happen in that regards. Follow up on potassium levels as well. So the strategies you can do is to protect the heart from this potassium using calcium, which stabilizes the membrane. You can push the potassium into the cells using insulin and dextro drip or a beta agonist, or use a soda bicarb to produce the same picture of alkalosis, or you can increase the gastric excretion of potassium using loss either via the kidneys from furosemide or exchange raising like K-exilate, which will cause exchange of potassium in that perspective. And finally, you can use dialysis as an exchange mechanism. Now, you should go for an emergent treatment if there is paralysis or arrhythmia, which are acute symptoms, or the potassium is more than 7. So we have a higher cutoff in that perspective. But if there is a risk like tissue lysis, if your potassium is 6 to 7, you may also go for acute treatment in that regards. Now, rapid correction, very importantly, should be given in acute cases, treat the underlying cause, and most importantly, especially in individuals who are on all these medications, potassium supplements, ACE inhibitors, ARBs, potassium-sparing diuretics, they all should, of course, be stopped in that perspective. Now, calcium gluconate, you give 0.5 ml per kg up to 20 ml over 5 minutes as a slow infusion. If there is a cardiac arrest, now this is important, if there's cardiac arrest, calcium chloride may be more preferable in that scenario, and this has to be given using central line. You can repeat it if the ECG changes are persisting after 10 minutes. So you may repeat it just for prevention and protection of heart. You can use insulin dextrose to shift the potassium inside. So give 0.1 unit per kg, and for every 0.1 unit per kg, 500 milligram per kg is required. 10% dextrose should be used till 5 years, and later you can use 25% because volume can become an issue in certain scenarios. In severe cases, you can double the amount of the insulin dextrose that you're giving. Beta agonists like salbutamol in neonates 0.4 milligrams, infant 2.5 milligram will push the potassium inside the cell. Up to 10 years, you go up to 5 and then 10 milligrams. So this is one strategy which can help out immediately, even if you don't have an IV excess. Soda bicarbonate, again, 1 millimoles per kg over 10 to 15 minutes will push your potassium inside the cells. And very importantly, do not give soda bicarbonate and calcium gluconate together. They will precipitate and cause problems in that regards. Now, all these strategies are pretty much either protecting the heart or they are trying to shift it into the cells. You also need to remove it. So you can use exchange resins like sodium polystyrene sulfate, which can be given oral or rectal. Both modes will work, and repeat 4 to 6 hourly. Very importantly, neonates, you may have a problem because of obstruction and necrotizing enterocolitis. Furosemide will cause increased excretion in the urine. So 1 milligram per kg 6 hourly is affected. Somebody who has a renal disease will have resistance. You will need a higher dose. But if there is dehydration, avoid, you will cause more dehydration. Dialysis finally is the final mode, and hemodialysis is better than peritoneal dialysis for potassium excretion. If there is renal failure with potassium more than 6.5, go for dialysis in that regards. So to summarize the management, if there is paralysis or arrhythmia, you give calcium gluconate, insulin dextrose, soda bicarb, everything. Soda bicarb, beta agonist, dialysis and resin. If, however, you do not have these symptoms and the potassium level is less than 7, you may consider in that perspective more than 7, or if 6 to 7 and there is a risk of rise, you treat. Otherwise, you go ahead with a chronic management in that perspective. Treat the cause, stop ACE inhibitors and ARB. So the management is largely symptoms, any potassium levels. Without symptoms, level more than 7 or 6 to 7 with a risk of rise.